Uh, Good afternoon, everyone. My name is Joris Hemmenaar. I'm one of the organizers of the Richard Dole seminars. Thank you all for joining. I see that people are still joining, but I'll start by giving my introduction, and then hopefully by the time I finish that, then everyone who wants to join has joined. Before I forget, questions please in the chat, and I will read them out at the end of the talk. So today's speaker has just appeared, is Chloe Orkin, who is a professor of infections and inequities, which is an unusual combination, but it probably will come out in her talk why that is and how that applies to her, at Queen Mary University in London. And she's also an honorary consultant physician at Barts Health NHS Trust. She's very well known in my field of HIV research. She has had many roles in the past and also currently, among which are that she is past president of the Medical Women's Federation, past chair of the British HIV Association, and the governing council of the International AIDS Society. And because of her many contributions to the field, she was awarded the MBE earlier this year, I believe, for services to the NHS. And in preparation for this talk, I read a little blog about her thoughts about whether to accept that award, which was very enlightening. Her research in HIV focuses, at least I think currently, in particular on long-acting injectable treatment for HIV. And she has also been very active in the recent Mpox epidemic, so to say. And so the title of her talk is HIV and Mpox, Where Are We in 2024? So thank you very much, Chloe, and I look forward to your talk. I think you're muted still.
I'm muted because I was trying to put my blog into the chat. I was trying to be too clever and do too many things. So here we go. So it's a pleasure to be here, and thank you for the kind introduction. I'm going to talk, as we've said, about HIV and Mpox, and think about where we are at this point. Here are my conflicts of interest. So I'll talk to you a little bit about SHARE. So SHARE is a research collaborative which was established in 2021, and it really is focused around the interface between inequities and infections. And these two concepts are actually pretty much inextricably linked as a result of factors such as structural racism, sexism, and various social determinants of health. So I think that the types of research that we do is very much influenced by who we are. And as a young lesbian with lots of friends and contacts who were living with HIV in the gay community, it became really interesting to me and really important to me to contribute to this as I went through my medical school days. So this was the backdrop of how I grew up. In the 80s, I grew up with this terrifying illness, which was identified and then seen in lots of films and really affecting gay people, really gay men. And it used to be called GRID, gay-related immunodeficiency. It's interesting how we have not, even in COVID, we still name diseases after countries, but we can see that it was a lot worse than that in the 80s. So where have we got to now? Well, there have been 39.9 million people living with HIV, and currently 77% of adults are receiving treatment and fewer children, unfortunately. But I think one of the key barriers stopping us from getting to the point where we can actually end the epidemic is really being able to offer people treatments that they are able to take. We have all these treatments, but not everybody feels able or was able to make the daily good decisions needed in order to take oral therapy for many reasons. So we have a number of recently approved therapies, but we have come a long way since the 80s. So in the early days, success was defined as prolongation of life. And we had antiretrovirals, but it was handfuls handfuls of tablets that people had to take 3 times a day, people taking more than 20 pills a day. And then as treatment evolved over the years, things got a lot easier, and success became achieving a normal life expectancy with fewer side effects and more convenient dosing. And treatment has always involved a combination of 3 drugs dosed together. But in recent years, we've got to the point where less is more, and we're actually able to give people 2 drugs as part of an antiretroviral combination and put fewer compounds into a person over the lifespan. But we're also now in the position where there is actually a 2-drug combination, which can be given as a 2-monthly injectable treatment. And this liberates people from the burden of daily decision-making around taking treatment. So not everyone can or will take it, and there can be physical reasons and, like side effects or dysphagia. There can be psychological reasons around pill fatigue, anxiety, a constant reminder of living with HIV. And then there can be social reasons like fear of inadvertent disclosure and also things like convenience. And a lot of this really boils down to stigma. So we now have this treatment, which is 6 treatments a year, and you can see that it's entered into international guidelines, can be dosed 2 monthly or sometimes 1 monthly, but certainly in Europe, we dose it every 2 months, and it's 1 injection into each buttock. So it's a deep intramuscular injection. And it means that we have to see people 6 times a year instead of twice a year, as we normally do, to manage stable people living with HIV. It's not for everybody. It's for people who are virally suppressed with no resistance or reasons not to be able to take a 2-drug regimen. So people need not to have hepatitis B, and they need to not have any resistance to any of these drugs or have experienced virological failure on these classes of drugs. So what has been shown across a number of studies with these drugs, with cabotegravir or pivirine, is that when people are asked at the end of the study which treatment they prefer, do you prefer injectables or daily oral therapy? What you can see is that the preference question across all of the studies is extremely positive, and more than 90% of people prefer the injectable therapy in these studies. Now, you may say, well, obviously, these people chose to go into an injectable therapy study. And yes, of course, there is truth to that. But bear in mind that actually it takes us a lot more effort as clinicians to actually administer treatment every 2 months rather than seeing people twice a year for daily oral therapy. It's very clear that we're not going to be putting a gun to anyone's head and forcing them onto the injection. So what we need to know from the studies is that for those people who want the injection, they still wanted the injection by the end of the study, and this shows us that they did. Now, why do they want it? Well, one of the things that is becoming clear is that the treatment addresses psychosocial challenges. And when you ask people what the challenges are, they talk about fear of disclosure, they talk about adherence anxiety, and they talk about daily reminder of HIV. So this is what they want to avoid by taking the injection. Now, this particular study, the SOLAR study where this comes from, showed that at baseline, nearly 50% of people had at least one of these psychosocial challenges. And this is even more shocking and surprising given that this SOLAR study was conducted in nearly 90% men, 70% of whom were white, and they were around the age of 32. So we tend to think nowadays that everything's cool for people living with HIV, U equals U, undetectable equals untransmittable, can't pass it on, things are much better. But actually what patients are telling us is that isn't the case for them. They are still experiencing stigma. So we need to be aware of that in terms of what we offer them. So you can see the reasons, once again, I don't have to worry about taking my treatment every day. It's more convenient for me. I don't have to carry my pills. I don't have to think about my status. I don't have to worry about other people seeing my pills. So this is the same group of people, and these are their reasons. And I do think, that there is a sense that everything is great now. There's gay marriage and people with HIV, U equals U, and that there's no stigma or very little stigma in terms of LGBTQ plus issues and also about HIV, but this really patently isn't the case. We tend to associate stigma with certain communities, minoritized communities, but this is what the study is showing you, and many other studies too, is that we need to listen to our patients and ask them how they feel rather than thinking that we know what they are experiencing. So there you go. You can see it over there. So one of the caveats about long-acting treatment, this particular treatment, is that it has a lower genetic barrier than oral therapies. So our modern oral therapies are really, really potent. And if you switch someone from one therapy to another, you would expect a virological failure rate to be zero. You would not expect this to happen. But what we've shown is that actually with this therapy, although people prefer it, there is a small risk of virological failure. So between 1% and 2% of people will experience virological failure when switched to this treatment. But what we've also shown through multivariable analysis is that this virological failure is associated with having particular baseline factors. And therefore, by performing careful patient selection and understanding if people have archived resistance to the drugs, if they have a particular subtype, which is the A6 subtype, which is generally found in Russia and Ukraine, with the BMI greater than 30, these are risk factors. And what our study showed is that having more than 2 baseline risk factors, it really increases the likelihood. And if you do have 2 risk factors, the risk goes up to about 1 in 5. So significant risk versus like 0.4% without any risk factors. So we do have a tool that can help us to limit risk, but we need to use it. I think the other thing that this treatment has really shown me is that I'm finding myself having to communicate risk in a way that I've never actually had to do or think about in the same way before. Because I will present these risk factors. You have 1 risk factor, you have 0 risk factors, you have 2 risk factors, and what this means in terms of what could happen. And I've had to learn through shared decision making that actually my risk perception and what I'm willing to tolerate in terms of risk may be different from somebody else's. And it's also about, it's about power sharing and understanding that this is a relationship and the patient is the knower and the expert and on them. And I need to convey the risk to them so they can appreciate what the risk is. And then we come to a decision on what's best for them. So what do we need going forward? Well, what we need is, what would be ideal is a regimen that is suitable for self-administration at home. In other words, in a non-medicalized setting. Less frequent injections will be helpful, so even longer-acting drugs. And also a wider indication, treatment that can be used in non-virally suppressed people with a higher genetic barrier, so less likely to lead to resistance. So how's it going in terms of implementation? Well, as you may have noticed on the slide, the drug has been licensed since 2021, and it came much later to the NHS because of all the approvals through NHS England and NICE. But in other countries, they've been implementing it for several years. In the NHS, it's been about nearly 2 years. And what's happened across the world is that across the phase 3 trials, around 25% have been females, 28% have been people of color, and only 18% have been over the age of 50. And then in real world studies, it's even worse. And what we're seeing is that there are lower proportions of female participants than the relative country proportions of females living with HIV, which led us within the Share Collaborative to establish the Alana study, which is a UK-based multi-site study looking at implementation of cabotegravir pivirine in the clinic and also seeing if we can implement in the community. The study is an explicitly anti-racist, anti-sexist, and anti-ageist design. And we've published the protocol, which is looking at an inclusive approach to recruitment. And we did actually manage to recruit at least 50% women, at least 50% people of color, and 40% people over the age of 50. So we met those targets and we very explicitly set them because we didn't want to repeat these patterns of inequity in terms of who is included in the studies and what knowledge we end up having about the use of the drug. And I'm pleased to say that this Alana study has actually been published yesterday in CID, and we're publishing the perspectives of people living with HIV on this implementation. And we will also be publishing on the healthcare provider perspective in due course. There are other drugs coming. So we have lenacapavir, which is a first-in-class capsid inhibitor, which can be delivered 6 monthly by subcutaneous injection. And it's licensed for people with no other treatment options. So unlike cabotegravir or Privorine, it's not a complete regimen. It has to be given with other oral therapies, which limits its utility to free people from the burden of daily oral therapy in the context of treatment, okay? Now what we want clearly in the future is perfect choices for all. We want people to, like in the situation of contraception, to be able to choose whichever modality is suitable for the person. And interestingly, we are now moving to the phase where we're developing longer acting oral therapies. There are weekly oral therapies in development, and there are also drugs in development and early development in terms of patches, implants, and other long acting injections. You can see we have quite a deep pipeline in terms of compounds in clinical development, but it's important to recognize that although we have a lot of classes and a lot of drugs in development, not everything that's in the laboratory at the bench actually reaches the bedside. And we have actually in recent years seen drugs falter in phase 3. And sort of certain drug was identified with significant adverse events in phase 3. So this can still happen, which is why it's important to have a pipeline. So I mentioned lenacapavir. We also have long-acting injectables being developed for PrEP, which is pre-exposure prophylaxis. PrEP is a way of preventing people from getting HIV, and it's for anyone who wants it, so long as they meet criteria for use. In other words, they need to be at risk of developing HIV. We already have an injectable PrEP that exists. Cabotegravir, it's cabotegravir on its own, so it's half of the regimen that I was talking to you about for treatment. Just the one drug is needed, and it's given every 2 months. It's well tolerated, and it's been recommended by various agencies, regulatory agencies, and is available in several countries. So far, NICE has reviewed it, and the review is out to consultation, but they have not passed the use of cabotegravir as cost-effective currently, which is a problem. So there is lenacapavir, which can be used on its own, 6 monthly as a subcutaneous injection. And there have been 2 very important studies, the Purpose 1 study and the Purpose 2 study. Purpose 1 was for adolescent girls and young women, and the Purpose 2 for men, transgender men and non-binary people living with transgender women at high risk. And it's lenacapavir is basically the study design is factorial design, and the efficacy is compared against a potential incident population. So we now have some results, and in the adolescent girls and young women study, we saw an unprecedented thing, which is that there were 0 new infections in the study. So obviously it was superior to the oral PrEP. But in the men's study, there was a 96% reduction in HIV infections compared to background HIV incidence. So the results are superlative and really spectacular. And I'm really excited that in 2 weeks' time, we will be hearing the results of the Purpose 2 study presented, the primary outcome presented at the HIV Glasgow meeting, which I chair. But we have already got the NEJM paper on the women's study. So if you want to read this paper, it's out in NEJM, and it's a very exciting paper to read. So I'm going to move from HIV to Mpox, and I'm going to talk a bit about how I became involved in Mpox and give you a whistle-stop tour of some of the things that have happened during the Clade 2B outbreak, which started off in 2022. But I'll start by giving you some global perspective. So in terms of surveillance, what we can see is that the cases, which were very high in all different regions in 2022, have generally gone down. There's very few reported cases of Mpox in different WHO regions, except for Africa, where you can see that there's been an enormous increase in numbers of cases. And you may have heard, but there is a particular outbreak that's going on. There's a new strain, there's a 1B strain, which is circulating, particularly in the Democratic Republic of Congo and surrounding countries, and is an infection of concern. And that's currently happening. So there are a number of different outbreaks occurring in Africa. There's the 2B outbreak, there's the 1B outbreak, and there's also still the 1A, which is the subtype, which is localized to Central Africa. So in 2022, as I mentioned, we started the Share Collaborative in 2021. I was going about my business, and the outbreak started to occur in May 2022. And being in a group which focuses on infections and inequities, we realized that this infection was affecting men who have sex with men. So we decided that we wanted to try and respond to this outbreak. So I approached clinicians through my research networks in different countries, which I could see on the maps were being affected because cases were being reported week by week to the World Health Organization. So I reached out to my contacts and I asked them if they had any cases. And then if they said no, I asked them to refer me to colleagues that they knew in their country who may have had cases that they'd heard of, and eventually gradually established a network in 22 countries, which we called ShareNet. And we've written a paper describing the process of setting up this collaborative group called Sharing to Create Knowledge in a Crisis, which is published in V&J Leader. But basically, what we did in terms of Share is we focused on delivering research in certain areas. So we focused on case definition, firstly, and produced a number of global case series. Firstly, the first global case series on which tended to cover men. Then we specifically and intentionally did a case series to describe the disease in women. And then we focused on people with advanced HIV. And then we looked at what happened in terms of reinfections and post-vaccine infections later on. We also worked with marginalized communities to co-produce a community survey on public perceptions of media representation and also policy, public policy and how people were receiving the public health messages in the UK. And I worked with the WHO in terms of the community group, in terms of the interventions that were being developed. We worked with the World Health Organizations. We were commissioned to deliver a systematic review on behavioral change and also some qualitative work on Tecovirimat. And then we also engaged a global survey for healthcare providers to try and understand how people were experiencing this outbreak. So the first case series covered 528 people in 43 centers in 16 countries. And it was published very early July, and the outbreak began sort of in the middle of May. So it was a rapid publication and really describing the mucosal features that were so prominent in this particular outbreak. And this we motivated for mucosal symptoms to be written into the case definition, which did eventually happen. Probably the most relevant and important of these publications was really the case series on advanced HIV. We were able to collate 382 people, and almost half of them had CD4 counts less than 200, and 1 in 5 had a CD4 count less than 100. Half of them were not on effective HIV treatment. And what we showed is a very severe necrotizing form of Mpox in advanced HIV. We identified that immunorestitution events were occurring, and we called for Mpox to be considered an opportunistic infection, which was quite a big ask, given that there have been no opportunistic infections identified since the 90s. But actually, some guidelines have accepted this, and for example, the European guidelines have accepted this and written it into their guidelines. And we thought this was very, very important because we wanted to show that the disease that people were experiencing in advanced HIV is completely out of keeping with sort of the much more mild disease that we were seeing outside of the advanced HIV. The mortality was very high. It was 15% in people with CD4 counts less than 200. Bear in mind that the mortality for the clade 2B outbreak overall was 1 in 1,000. So this is very, very significant. And in people with CD4 counts less than 100, the mortality was 30%. So it's massive. And you can see panel B7 at the bottom, at the edges, you can see that these edges are teeming with virions, and that the immune system is completely unable to contain the infection. There were also internal organs also affected. There was a nodular picture in the lungs, and various other organ systems could be affected. You can see the lungs on the left, and I was being sent multiple CT scans from people all over the world asking me about it, if I knew anything about nodules, and we did see a lot of this in people with advanced HIV. We thought it was important to publish a paper describing women and non-binary individuals during the 22 outbreaks, and we reported 136 people. 62 were trans women, 69 were cis women, and there were 5 non-binary individuals. We disaggregated the data at all times throughout the paper, and between the transgender women and the cis women, at no point did we conflate the groups in terms of what we found. We found that 34% of these people were initially misdiagnosed, 90% had had sex with men. Nearly a third were living with HIV, and this was much more so in the transgender women. We found that sexual contact was a major suspected route of infection, particularly in transgender women, but also in 61% of cis women, which of course means that cis women were also suspected of having acquired Mpox in other ways. It looked similar, and we did identify MPXV DNA from several vaginal samples that were taken. And you can see that this is what it looks like in women, very similar to what it looks like in men. So how is the outbreak contained? Well, behavioral change in collaboration with MSM communities and vaccination. So a smallpox vaccine, the MVA Bavarian Nordic, which is known as Jynneos or Imvanex, the 3rd generation live replication deficient modified vaccinia ankara vaccine, is given 2 doses, 28 days apart. Second dose is very important, particularly in HIV. It's recommended to people to prevent it from happening, so people who may get it, as a pre-exposure vaccination, and it's also recommended as a post-exposure vaccination if someone is exposed within a short period after exposure. Usually within the first days, it's most effective. And you can see that it's been recommended for MSM, for lab personnel working with orthopox viruses, and potentially for other people who may be at risk. They note that the World Health Organization notes that some groups may be risk for more severe disease, such as children, pregnant women, people that are immunocompromised. The European AIDS Society comments specifically that Mpox can be life-threatening as an opportunistic infection in people with CD4 counts less than 200. It talks about people with HIV who may have had recent or anticipate potential exposure as being people that should be vaccinated. It says that in the case of vaccine shortage, people with HIV should be prioritized, and also prioritized for post-exposure vaccination. So the EACS guidelines particularly focus on looking after people with HIV and prioritizing them for vaccination. So I know you can't speak, but you can certainly raise your hands amongst yourselves and think about this yourselves. What is wrong with this photograph? This is a cue for vaccination. And if you've said they're all men, that is not what's wrong, because that was the community that was at risk. What's wrong is that they're all white. And the reason that they're all white is because Mpox was known as a disease affecting gay people. And people from minoritized communities, racially minoritized communities, are not happy to stand in the street and be identified as being from the MSM community by anyone who walked by. And these are pictures which are in the US, they're in France, and they're in America. This happened everywhere. However, what's important to say is if we look at, in America, the total US population, 60% are white. However, 30% of MPXV cases with ethnicity data were white, and yet 52% of the vaccines went to white people. So it is really important to realize that how we offer interventions defines who will take up those interventions. And it's no use blaming people and saying that people are hard to reach. We need to look at the interventions that we offer and look at them critically and think about whether they're appropriate. So Biot's Health went off to Black Pride. We sent a little delegation off. And we did a very low-key pop-up event together with the Love Tank CIC community organization, and we offered vaccination to people attending Black Pride. You can see our bus, which thankfully has been replaced because it was becoming a liability. The vaccine effectiveness, this is data from America. They've collated vaccine effectiveness from the different studies. There's some case-controlled studies. There's sort of just write-ups of case coverage. There's some retrospective cohorts. And you can see that the coverage tends to be, that the vaccine effectiveness tends to be pretty high. It does range depending on how well controlled the study is. You can see it's sort of at its worst in the Deputy et al. Study, which is a very well-designed case-controlled study published in the NEJM. But most optimistically, it could be up to 90% effective. Certainly, what we know is that those vaccinated had a lower risk of hospitalization in the real world. Those vaccinated with PrEP, pre-exposure, with 1 dose, those vaccinated with 2 doses, and then you can see in post-exposure prophylaxis, it also had an effect. And it's important to note that a large proportion of these people were living with HIV in this particular write-up. And this was from the California Department of Public Health. So what about people who've been vaccinated or who have natural immunity as a result of a vaccination course? So this was our 4th case series, and we managed to collate from a number of different countries a case series on 37 gay and bisexual men who had sex with men. 7 people had prior infections, and 29 people had infections after 2 appropriately spaced vaccines. And 1 poor person had an infection that met the criteria for both reinfection and infection after vaccination. We used a severity score, which had been developed by one of our collaborators in order to compare the severity in the first infection and later on. What we found is that those with natural immunity after initial infection had a shorter disease course with less mucosal disease upon reinfection than with their initial infection. We found that infections post-vaccination were also less severe, less mucosal disease. And overall, there were no deaths, no bacterial superinfections, and everyone was managed in the clinic. Everyone, in terms of HIV, some proportion of the people were living with HIV. However, everyone had a very good CD4 count and was well. So it was we don't have any answers here for the advanced population. And this is the poor person who had a vaccine, dose 1, 32 days later had dose 2, and then on day 36, so effectively after 1 effective vaccine, developed Mpox, and then carried on, reported an Mpox exposure at day 290, and then went on to develop Mpox. So this was quite an awful situation, and does certainly raise questions around immunity. This was not a person living with HIV or any known immune disorder. So what can we do if someone gets Mpox? Well, we do have a treatment. It's called Tecovirimat. It's approved for smallpox and under the animal rule, and it targets an envelopment, BP37, which is required for envelopment of the immature virus. And it's broadly active in vitro against orthopox viruses. You can see that in clade 1, which is the more severe clade, which is generally known to be found in Central Africa, when it's inoculated into macaques, it reduces the viral load, it reduces the lesion burden, and it also increases survival. So that's in animal models, in non-human primates. In humans, it's been used in a number of sort of cohorts, particularly in the US. They're small cohorts, and they looked at a treatment outcome in 80 treated people versus 35 people who weren't treated. And what you can see in the red box is that it suggests that it shortens duration in severe disease, especially, but they're very, very small numbers. So you can see that in severe disease, you can see some suspected shortening, but in non-severe disease, it didn't appear to shorten the duration, but it is very small numbers. There are some other cohorts which show similar findings. So I think the general feeling about Tecovirimat in clade 2B virus is that from clinicians that it's potentially shortens the duration, there was no real concerns in terms of safety signal. So people were using it to try and reduce the severity. However, there were some randomized trials set up for during the clade 2B outbreak, but it was right at the end when there were very few cases. So none of them have really recruited. So we don't actually have a study in clade 2B virus. But the PALM-007 study is a randomized control trial, which was conducted in DRC with 600 people with the clade 1 virus, and people were randomized to weight-based dosing of Tecovirimat or placebo over 14 days. Participants were adults and children with lab-confirmed Mpox of any illness duration with active lesions. Everyone was hospitalized for the duration of treatment, received antibiotics, hydration, support, nutrition. And the primary outcome was time to complete lesion resolution, secondary outcomes around mortality, safety, symptom resolution, and viral shedding. And there were no significant differences in time to healing of lesions and no significant difference in mortality. Okay, but what we did see is that mortality for this clade 1 infection was much lower than is normally reported. What's normally reported in clade 1 is a range between about 4 to 10% mortality. So we can see here it was 1.7%, which is much lower, which really shows the importance of supportive care. So in these people, in both arms, when people were admitted to hospital and looked after, the outcomes were a lot better. And you can see that it was safe and well tolerated with no drug-related SAEs. The authors have commented that there was a meaningful improvement observed in participants receiving Tecovirimat within 7 days. So we need some more information here. What about resistance? Well, resistance can occur in the vaccinia gene, which confers resistance to Tecovirimat. And what we've seen is very similar to in COVID, that when the drug is used in immunocompromised persons for a long time, resistance can occur. And this is just a map in America showing distribution of people with Mpox who had samples received for Tecovirimat resistance assessment in panel A, and who had samples confirmed to be resistant in panel B. So you can see that it certainly did occur, but in sort of small frequencies. So my final point in terms of the research that we did was really, what about healthcare providers in all of this? It's our second pandemic in a very short period of time. So we conducted a large international survey, as I mentioned, and we've already published the survey of the sexual health professionals' experiences and perceptions in the UK, and it was not a pretty picture in terms of people's experience of how it went. Really depressing findings. And we've also put up a preprint from the International Healthcare Workers' Experiences and Perceptions of the 22 outbreak, and we've submitted it. It's being peer reviewed at the moment. But I think really we focused on training. Did people feel adequately trained to diagnose and recognize it? Did they misdiagnose it? We focused on moral distress. We focused on moral injury. We focused on how supported people felt by the public health agency in their country, and where did they get their knowledge, where did they get their information from, and we also focused on whether they could access vaccination. So I think it's important to think about healthcare providers. We are not a sort of infinite resource, let's put it that way. And I think infectious disease physicians particularly have had a hard rap in the last few years, as has everybody else. But I think the two pandemics have been tough. I think it's important to talk about the fact that people think that Mpox has gone away. People stop thinking about it. But there is this really massive clade 1B outbreak currently occurring in DRC, which is also affecting neighboring countries. I haven't focused on this because I was asked to focus on my research, and this isn't something that I've been involved with. But I think it's important to say that the reason that this has happened is because there's very little ability to do surveillance in these countries, because there's been very little interest in Mpox. This is a virus that was first identified in lab animals in 1950. The first human cases in 1970, which means we've had this virus in humans for more than 50 years. This is nothing new to anybody. The fact is it's been a neglected disease. It's something that's occurred in the rainforests of Africa, and people have, quite frankly, there's not been much interest in this disease until it's sort of affected the global north. The clade 1 virus is much more severe, as I've mentioned, and the virus has mutated as the clade 2 virus did, and it's formed a new clade, which is the clade 1b virus, which has been found to be much more transmissible. We think it's much more transmissible, and it seems to be spreading also within sex worker networks. And it's affecting a very mobile population in a mining town region in DRC, and there's it's very close to the border, and the borders are porous, and there are also displaced people in refugee camps where there's very little hygiene. So basically the outbreak is very worrying. So Mpox has not gone away. And I did do an iPlayer resource, and it's sort of an educational resource on Mpox, and it sort of does cover the 1B outbreak as well. If anybody's interested, it's publicly available on iPlayer. I think it's important to say no one is safe until we're all safe, and we certainly need more vaccines, and we need drug to get to Africa as well. So we don't have enough vaccines to vaccinate people in DRC or in neighboring countries to prevent this from spreading. If anybody was unclear about what infections and inequities had to do with each other at the beginning of the talk, I hope that's no longer the case. I think I'd like to end on a note of activism, and I'd like to say that there is something that each one of us can do when things happen. And I think it's easy to feel disempowered with all of the terrible events going on in the world, but I think there's always something that each of us can do. And I'm inspired by this man on the left, Haroon Tulane, who was admitted to hospital with Mpox and went onto Twitter and chronicled his journey so that other people could understand what he was experiencing, to help other people to avoid it. And he's been since deeply involved in prevention, and he's sort of taken on a national role in sort of HIV, the clinical reference group. But it all came to the fore because he was willing to speak up and use his voice to try and help others. In my little way, I did my best to try and argue for case definitions to be changed, and for Mpox to be considered to be an opportunistic infection, to try and protect people with advanced disease. And the day after we published the NEJM paper, you'll see that I wrote to the head of the CDC, Dr. Walensky. I also wrote to the infection lead of the WHO, AXA, EACS, explaining that I thought the definition of the case definition needed to be changed to include mucosal lesions. I think what this shows is that we all have a voice, we all have the ability to try and make change. And here's me and Haroon become a dear friend a few years later at a march. I'd finally just to say that I think collaboration is extremely important. And I think that academic environments are really competitive, and people tend to compete rather than to collaborate. And I think it's a great testimony to my colleagues that people were very keen to sort of join forces to try and produce a larger series rather than just writing up their own little series. And particularly with the advanced HIV case series, the families of the people, the deceased individuals who were so gracious and agreed to contribute data to further the knowledge of the disease. So I'm going to stop there and stop sharing my screen. Let me just stop sharing.
Thank you very much. I'll keep an eye on the chat here on the right. But before we have any questions, Chloe, maybe I can ask you, you talked a lot about, let's say, minority groups and trying to include them in your studies. And one of those, I would argue, is pregnant women. And I was wondering, in your HIV research, what your view is on how we can improve inclusion of pregnant women in treatment and prevention studies.
Yeah, thank you for raising that. So the Alana study that I mentioned is actually identified in the World Health Organization toolkit, which has just been produced, which is focusing on preventing women through rather than from research. So it's a toolkit on inclusion. of people who are pregnant and breastfeeding, because this population has been excluded from trials for their own benefit, in inverted commas, in a very patriarchal way. And this came out as a scandal a few years ago when a drug which was not tested, an HIV drug which was not tested in pregnant people because they had to be protected, ended up being rolled out by the World Health Organization to thousands and thousands of people. And what was found was there's a suspicion of a neurotubular defect signal, so an abnormality, a fetal abnormality. And then women were told, everyone was called in, all the guidelines changed, all women must be taken off this drug, it's dangerous, they cannot have this drug. Women were not consulted, the women were absolutely livid. And they had spoken up in their droves and said, this cannot happen anymore, we should be making decisions about our health, we need a stake in the game. So the Alana study is mentioned in the guidelines. Our protocol was that people were told that it wasn't a recommended drug in the guidelines. However, they were informed of this, and they were informed that they would have a choice whether they chose to continue it or not. They would not be taken off the study if they became pregnant unless they wanted to come off the study, and they would be monitored. So the World Health Organization toolkit has a very clear map on how to do this. It's got lots of protocols and guidelines to help people who are developing studies to do this safely, to do this well, and to follow best practice, because it is very important.
Yeah, I agree, of course. Yeah. I don't see any other questions. So just maybe to recap for Mpox. So maybe I missed a bit. So I think the treatments you mentioned, the Tecovirimat, it doesn't help much. Is that fair to say? Or
so in the clade 1 virus, where there's an actual randomized controlled study, it didn't help. But in the clade 2b virus, when we used it, in different countries, the clinicians felt that there was a reduction of severity and a shortening of the disease. There were very small clinical cohorts by that point, because by the time we had the drug available, the outbreak was going down and there weren't sufficient cases. So there are a couple of cohorts in America which suggest a shortening and reduction of severity, certainly suggest it's safe, but we don't have the answer because we didn't have enough people to enroll into the RCTs, which was set up in America and here. So we can't give a definitive answer, but we know in clade 1, it did not help in the DRC, but clade 2 is a different virus. It's a much milder virus, so maybe it would help, we don't know.
And is the current outbreak in DRC, is it clade 2 or?
It's clade 1.
Oh,
so there's multiple outbreaks. So there's the clade 1A outbreak, which has been there for many, many years. And then this virus has changed. The 1B outbreak is the one that's sort of spreading over the border and appears to be is affecting a different group. It appears to be sexually transmitted. Whereas it's normally the clade 1 virus often affects children and mothers, caregivers. So it's spreading in a different group of people. And it seems to be, there's a lot of concern that it's being sexually transmitted. The clade 2B virus is still out there in all the different countries in low levels. In some countries, it's in high levels than others, but in general, it's in low levels. But it's the clade 1 virus, which is in Central Africa, which is causing a variant of the clade 1 virus, which is causing the concern at the moment.
Yeah. And again, maybe I just, to get it clear, like the vaccine is essentially a smallpox vaccine. Is that right?
Correct.
And would you say, when you look at how your graph shows that in, let's say, the UK or Western world, it's no longer much of a problem, so to speak, can always come back. But what is that mainly due to? You think is true because of vaccination, or more behavioral change, or symptom recognition, or, what was the reason?
Yeah. So I think it's multiple things. I think the communities did change their behavior during that period of time, and that's been very clearly shown that the number of partners reduced, sex on site venues, reduced. But a large proportion were vaccinated, and a large proportion actually got Mpox in terms of sort of natural infection. So there was the population levels of immunity went up significantly in these countries where there was a large vaccination campaign. That was a big, that massively affected the outcomes. And I think there is evidence from the US that vaccinations did help, even in addition to past infection. So those were the key measures: vaccination, past infection, and behavioral change. So the vaccine definitely has had an effect on the population, but it is still possible to develop Mpox post-vaccination, but the disease appears to be much more limited. And not everybody does get it. So some people are in some people it's preventive, and in others it limits the disease. Because the reinfections post-vaccination is very small numbers. You know, we went back to more than 150, like 200 clinicians all over the world and said, have you had any post-vaccination cases? And we end up with 37. You know, we went out to, you know, hundreds of clinicians, and this is all we could find. So it's not common. It does appear to be at some level preventive.
Yeah. And when you say behavior change, is that just avoidance of intercourse, or does condom use also help? It's just my ignorance, I guess.
Yeah. I mean, condom use, it's sexual contact. So, you know, the skin is beyond, you know, so rubbing the skin, if the lesions are, you know, around the scrotum or, you know, elsewhere on, it's sort of, that wouldn't protect you. It is, the modality is sexual contact, close sexual contact, but it is also found in semen and vaginal fluids. So it is found there, and it is found to be replicating, but the primary mode is actual skin to skin contact. So condoms would help because they cover some of the skin, but not all of it. Yeah.
Okay. Shall we then draw to a close? Thank you very much. It was really a great talk, and I look forward to that paper you mentioned, the Purpose 2. Curious in the other groups whether the lenacapavir works. And thank you very much once again.
Pleasure. Take care.